Shoot. Okay, Assalamu alaikum. Can you hear me? All of the students?
Yes, sir.
Okay, so Dr. Tanveer Jilani is here from Aga Khan University. So in next 4 lectures, I'll be trying to cover the physiology of the blood, the normal physiology of the blood. And that includes 3 topics. The first 2 of them, which I'll be dealing today in next 1.5 hours or so, are the composition, properties, and functions of the components of blood. And the second topic which I'll be covering today are the blood groups. I'll be dealing with in detail in 2 lectures tomorrow to hemostatic mechanisms which try to stop bleeding from a injured vascular wall. And those 2 lectures are in detail, are complex, have been covered in more than 1 chapter in the textbooks of the physiology. So be on time, and I'll be trying to be 5 minutes earlier than the scheduled time, which is 11:30 tomorrow. So should I start my first topic, which is the properties, composition, and the normal functions of the blood components? Can you hear me?
Yes, sir.
Okay. So what do you know about blood in terms of its components?
It's
Anyone?
connective tissue. It's a connective tissue.
So why do we call it a,
Specialized connective tissue.
yes, why do we call it a specialized connective tissue? What do you mean by the term connective tissue? What does the blood connects? By the way, when you use the word specialized connective tissue, this is in terms of physiology, not anatomy. Blood never connect our tissue to another tissue anatomically. No. What do you mean by specialized connective tissue? So, because blood, which is formed primarily in the adult life, in the bone marrow, in the long bones, and some of the membranous bones, once it is released into the systemic circulation, once it goes from one tissue to another tissue. So for example, once it goes from the heart to the lungs to become oxygenated, it is now connecting heart to the lungs physiologically. Vice versa, once the lungs makes the blood oxygenated, and this oxygenated blood through the heart then is pumped into the systemic circulation, and through the systemic circulation from the aorta, it goes to many of the organs, muscles, bones, etc. In this manner, the lung is being connected in terms of oxygenated blood to the bone. However, if you see any anatomical relation, lung is never in contact with any long bone. So in this manner, this is one example where the blood serves as a specialized connective tissue to physiologically, functionally connect one tissue to another tissue, which may be far apart. And we know that blood also serves, in terms of its functions and properties, a transport tissue. So it transports respiratory gases in terms of the red blood cells. It transports antibodies, cytokines, many pro and anti-inflammatory chemicals from various organs to the place where they are needed. It also transports many of the plasma proteins wherever they are required. And most of the plasma proteins, primarily in the human adult life, are formed in which organ? I again repeat my question. So if one of the function of the blood is to transport plasma proteins, it transports plasma proteins from which organ where they are mainly formed in adult life? Can anybody answer me?
Sir,
What
liver?
is the primary
Liver?
organ which forms the plasma proteins in adult life for humans?
Sir, liver?
Yes. So most of the plasma proteins which are either formed or stored in the liver, they are transported through this blood circulation to the areas where they are specifically required. Blood, we know, has got a red color. And why? Because red blood cells contain hemoglobin, which gives red color to the overall blood. Blood, in comparison to water, is slightly denser and more viscous. And this is primarily, again, due to the plasma proteins in the blood. The total blood volume of a healthy adult male, 70 kilogram, ideally, is about 4 to 6 liters, which makes about 8% of the body's weight, in which it is primarily divided into a fluid portion, which is plasma, which is about 55% of this 4 to 6 liters of volume, and the blood cells, which are also called as formed elements, which makes the rest 45% of the 4 to 6 liters of total blood volume. The normal pH of a healthy person in normal physiological condition ranges between 7.35 to 7.4. So is it alkaline slightly, or is it slightly acidic?
Alkaline. Slightly acidic.
No. Anything which is less than 7.0. I hope everybody has read organic chemistry. Any fluid, whether endogenous or exogenous, and I again repeat, any normal fluid कह रहा हूं मैं, chemical नहीं कह रहा, any normal exogenous or endogenous body fluid. Exogenous कौन सा हो सकता है? You give normal saline, you give glucose, dextrose, water. Anything who has a pH less than 7.0 is acidic, and any fluid which comes inside the body or is produced by the body who has got a pH greater than 7.0 is alkaline. The cutoff is 7.0. So therefore 7.35 to 7.40 is slightly alkaline. And why? Because blood which is present in extracellular fluid has a slightly excess of bicarbonate ions and chloride ions. Bicarbonate makes the blood more alkaline in comparison to bicarbonate composition in the intracellular fluid. One of the important reactions which occurs in the blood circulation in the plasma, as well as Izra gaur se suniega, one of the important chemical reaction which occurs in the plasma as well as inside the red blood cells, erythrocytes. And keep in mind, the mature erythrocytes don't have a nucleus. They only have cytoplasm. So inside the cytoplasm of red blood cells, erythrocytes, circulating erythrocytes, and in the plasma, a chemical reaction which is common always in all conditions, whether acidic pH, alkaline pH, etc., occurs. And this chemical reaction, I have repeated many a times in my previous lectures, is where carbon dioxide is present either in the plasma or inside the erythrocyte, readily combines with water, and water is present at both places. It is present inside the cytoplasm of erythrocyte as well as water is present in the plasma. And carbon dioxide, as I said, is present at both where. I hope you know that carbon dioxide is transported as carbon dioxide in the dissolved plasma also. So carbon dioxide quickly combines with water to form in a reversible reaction carbonic acid, H2CO3, and the enzyme is carbonic anhydrase. That will be present therefore both in plasma as well as inside the erythrocyte. And radially, this is a reversible reaction. Carbonic acid breaks up, dissociates into hydrogen and bicarbonate. Now, if at any place either in the plasma or erythrocyte, there is more excess of hydrogen, it is to be removed out. And if there is excess vice versa of the bicarbonate, either in the plasma or inside the RBC, it has to be removed out. If hydrogen is removed out, that's a corrective measure for acidosis. If bicarbonate is removed out either from the plasma or erythrocyte, this is a corrective measure to correct the alkalosis. And keep in mind, again, the enzyme is the same one for this reaction, which is carbonic anhydrase. However, if the bicarbonate is gone out of the erythrocyte into the extracellular fluid, a negatively charged substance is going out. So therefore, it has to be replaced by a negatively charged substance from the ECF into the cytoplasm of erythrocyte, which is chloride. And this exchange of bicarbonate from the cytoplasm to the ICF intracellular, to the ECF in cases of alkalosis, this is called as chloride shift phenomena. In this manner, and there are other examples where the buffers are secreted by the kidney or by elsewhere, by the bone into the blood circulation and carried at the places where there is required buffering action of those buffers to maintain acid-base balance. Therefore, one of the important property and function of the blood in general is the buffering action and to maintain acid-base balance. The partial pressure of oxygen is around 80 to 100 millimeter of mercury in the blood, circulating blood, and the partial pressure of carbon dioxide is between 35 to 45 millimeter of mercury. And I hope you know that why do we measure either in the plasma or in the air or in the lung partial pressures, not the total pressure. The saturation of hemoglobin in terms of oxygen saturation, how much of the oxygen saturation of a normal blood is, this is between 98 to 99%. And you might have noticed as a practicing doctor, especially during the COVID-19 era, that we always are bothered in terms of the decreasing or increasing oxygen saturation of the blood in terms of the respiratory effects of the COVID-19 virus. Are you with me? Is there anything which needs clarification in all of these general properties of blood? Any query before I move on?
Yes, sir.
Yes, sir. क्या मतलब?
Sir,
We are
chloride
with
shift
you.
बता दें, please.
Yes. I can't hear you, but can you repeat your sentence?
Sir, chloride shift kindly बताइएगा दोबारा.
Beta, a reaction which can occur either in the plasma or inside the erythrocytes, cytoplasm. At both places, carbon dioxide is available, water is available, both combine to form carbonic acid. The enzyme for this reaction is carbonic anhydrase. Carbonic acid, by again a reversible reaction, quickly dissociates into hydrogen and bicarbonate. Now, if either in the plasma or inside the cytoplasm, hydrogen of the erythrocyte, if the hydrogen is in excess, it has to be removed out of the cell or the plasma. Vice versa, if bicarbonate is more in excess, either inside the RBC, erythrocyte, circulating erythrocyte or plasma, it has to be removed. Hydrogen, we have seen in the kidney, can be removed by many mechanisms, including secondary active counter transport with hydrogen, with sodium, primary active transport, etc., etc. Bicarbonate, if in excess, it diffuses out through simple diffusion through the membrane of the erythrocyte from the cytoplasm into the circulation. Because bicarbonate is a negatively charged substance which is removed out of the erythrocyte cytoplasm, a negatively charged substance has to replace it inside the cytoplasm of erythrocyte. And the second most numerous negatively charged substance present in the ECF or the blood is chloride. So chloride enters from the ECF into the ICF through simple diffusion, and bicarbonate goes out. This exchange of bicarbonate from the cytoplasm of the erythrocyte into the circulation and movement of chloride for its place from the ECF into the ICF of the erythrocyte, this phenomena is called as chloride shift. Shift kiski? Bicarbonate or chloride ke darmiyan shift phenomena. Is it clear now?
Yes, sir. Thank you.
Now, moving on to my next topic, which are the composition, counts, and functions of the blood. Next. Okay. As I said, the first of the component of the blood, which is more in quantity, 55% of 4 to 6 liters is plasma. The plasma basically consists of 3 main portions. 1, water, which makes the plasma fluid. 2, the inorganic and organic substances, except proteins, and these include electrolytes, glucose, amino acids, fatty acids, both saturated and unsaturated, vitamins, especially those vitamins which are essential vitamins not synthesized inside the body, comes from the diet, cholesterol, and these all are end products of carbohydrate and lipid metabolism. And also metabolites from many of the metabolic cycles, hormones secreted through exocrine and endocrine glands, enzymes, waste products, and we have seen the fate of nitrogenous waste products last time through the kidney, and drugs. All of them are dissolved in water. So water plus rest of them makes the first 2 components of the plasma. The third main component of the plasma are proteins, and the major proteins, by the way, the normal concentration of the plasma proteins is about 4 to 6 gram per 100 ml of blood. The normal plasma protein concentration averages between 4 to 6 grams. ये माइक्रोग्राम मिलीग्राम नहीं है, ग्राम है. ग्राम इन 100 ml तो बहुत क्वांटिटी है. 100 ml में 4 to 6 gram is a large amount. It's not in milligram. Usually हम चीजें मिलीग्राम में मेजर करते हैं या millimoles में मेजर करते हैं. So 4 to 6 grams of proteins per 100 ml of blood, which is deciliter. And these includes the plasma proteins. The major ones include, and I'll talk individually in a moment, albumin, globulins, and all of the clotting plasma proteins. The first of them, albumin, which is the most numerous one. Why is albumin, if you remember my previous lecture, was not allowed to cross the filtration barrier to become part of urine? Why? Anybody who remembers the previous one?
Sir, because of
Because of
size.
size of molecule.
size
10.
बढ़ाई.
Okay. So the normal functions of the albumin, which is the most numerous plasma protein, is to maintain plasma osmotic pressure. And therefore, this is one of the major substance inside the plasma, which is called as osmotically active substance. Wherever albumin will be present, it will try to promote osmosis and maintain the plasma osmolality. The second major function of the albumin is to transport substances like calcium, free fatty acids, steroidal hormones, which include testosterone, estrogen, estradiol, progesterone, bile salts. And I hope you remember the metabolism of the bile salts and bile acids. Bilirubin, which is one of the end product of the bile metabolism, thyroxine, and many of the drugs which include barbiturates and warfarin. For all of them, albumin serve as a carrier protein. So if somebody asks you, what are the two major functions of albumin?
And the
Maintenance
plasma osmotic pressure.
and serving as a critical, essential carrier protein for many of the important things. How important are fatty acids for your body? How important is calcium? What is the role of thyroxine in the body? You can think about. And if albumin was not there, can these drugs be removed from their site of action and be excreted? Or can they reach the target organs? No. So hypoalbuminemia, which is one of the very common clinical condition, occurs especially in chronic or acute renal failure, dietary deficiencies, poor dietary sources intake, or any protein wastage disease will interfere in the normal functions of the albumin, and therefore all of these functions will be decreased. Talking about the second most numerous plasma proteins, which are globulins, and they are classified as alpha 1, alpha 2, beta 1, beta 2, and onwards. And according to the functions they perform, the globulins, they are under the following functional classification. The transport globulins include transferrin, which is a transport protein for
Iron.
ceruloplasmin, which is a transport protein for
Copper.
and
Copper.
lipoproteins, which are transport proteins for cholesterol, triglycerides, fatty acids, etc. So many of the transport functions are being done by transport globulins, which are part of the plasma proteins. Second, they are the essential. Essential वो चीज होती है जिसके बगैर जिंदगी मुमकिन ना हो. They are essential component of our both natural immunity as well as acquired immunity. And these includes immunoglobulins. And I hope you remember the relation between the B lymphocytes, plasma cells, and the immunoglobulins, which are of 5 types, and they all contribute both in natural immunity as well as acquired immunity. The complement components, C1 and onwards, which are also called as acute phase proteins, involved especially in acute inflammations. Cytokines, and there are a number of cytokines which are involved in the immunity functions, and these includes immunoglobulins, various types, prostaglandins, many forms, tumor necrosis factor, many forms, and interferons, alpha, gamma, many forms. They all are part of your defense and immunity mechanisms. So these all are globulins in nature and thus provide protection in terms of immunity, both natural and acquired, to the human body. Once the blood clot is formed, the fate of a blood clot can be, the blood clot can be repaired, can be replaced by connective tissue, which forms the scar. And that connective tissue primarily are fibroblast and collagen. The second fate of a clot can be, it can be dissolved by specialized proteins, which are part of the plasma. They are initially in the inactive form, which is called as plasminogen. जिन जहां भी होता है वो वाला जिन नहीं, जो बचपन में हम वो जिन सुनते, वो नहीं जिन, वो कहती नहीं ना, माए कहती थी बच्चों पे जिन आ गए, वो वाला जिन नहीं. So plasminogen. Once the clot has to be dissolved.
Sorry to interrupt. एक आपने chat box में देखे. In previous lecture, we were told T4 is bound to globulin. Mostly here, sir have mentioned albumin.
Yes, part of it is also bind to the albumin. So plasminogen, which is in inactive form, is also called as fibrinolysin, is converted into plasmin or fibrinol, or the inactive form is called as profibrinolysin or plasminogen, which is converted into plasmin or fibrinolysin. And as the name suggests, will do the lysis of fibrin clot. This plasminogen, being the globulin, is a part of the plasma protein. Then some of the acute phase reactant inflammatory proteins, which are markers of acute inflammation, which include C-reactive protein. And I hope now you know the importance of C-reactive protein in comparison to the ESR, which we used to do for measurement of inflammation. Haptoglobulin, alpha-1 antitrypsin, and ferritin, they all are called as acute phase inflammatory proteins. Their concentration rises during acute inflammations. They all are part of the globulins, and thus the globulin serves the functions of transport, defense, clot dissolution, and they are important during acute inflammation. Then comes the final one, and these three, the clotting factors, which I'll be talking tomorrow in detail, inclusive of prothrombin and fibrinogen, they all are involved in maintenance of normal hemostasis, preventing the blood loss from the injured vessel during blood coagulation. So these are various plasma proteins, and these are the functions of the plasma proteins. Any question, any query before I move on? The plasminogen is inactive form, which is stored as what are called profibrinolysin. Once it has to be in the active form, some of its peptides will be cleaved, will be converted from profibrinolysin to fibrinolysin. And as the name suggests, the name fibrinolysin and plasminogen is, plasmin is same one. Fibrinolysin will cause lysis of the fibrin clots. Should I move on, beta? Is there any question?
Yes, sir. Move on.
Okay. Now, once I have given an overview of the plasma proteins and the functions of the rest of the plasma, which was making 55% of the total 4 to 6 liters volume of the blood, then comes the discussion about the blood cells. And in this diagram, I have tried to show the main blood cells. The most numerous one in terms of the total quantity is erythrocytes. The average count, regardless of the gender and the age, of erythrocytes is 4 to 6 million cells per microliter of blood. Again, repeat. Erythrocytes are the most numerous one. क्यों? क्योंकि उनको ऑक्सीजन और कार्बन डाइऑक्साइड हर जगह टैकल करनी है, हर सेल तक जाना है, even to the deepest tissue. 4 to 6 millions of erythrocytes per microliter of blood, which is also called as cubic millimeter. The next most numerous one are lymphocytes in terms of their function. And the most numerous lymphocyte is this one, which is called as polymorphonuclear neutrophil. The second most numerous white blood cell, which are also called as leukocytes, are these lymphocytes having kidney-shaped nucleus. The third most numerous in terms of the white blood cells or the leukocytes are monocytes. Then are eosinophils, and the least one, which are less than 1% of the total of the leukocytes, are basophils. Once monocytes becomes activated, they may be converted into circulating macrophages, or they go to the tissues, become fixed there, and are called as fixed tissue macrophages. The last one, whose amount are in lakhs, between 150 to 4 lakh cells per microliter of blood, are platelets, which are also called as thrombocytes. While the leukocytes total count normally is between 4 to 10,000 cells per microliter. So 4 to 6 millions of erythrocytes per microliter, 4 to 10,000 leukocytes per microliter, and 150 to 400 lakhs of thrombocytes per microliter. Would you remember this round figure? I can again repeat in general. 4 to 6 millions of erythrocytes per microliter, and microliter is equivalent to cubic millimeter. 4 to 10,000 of leukocytes per microliter, and 150 to 4 lakhs of thrombocytes per microliter of blood. This is normal average composition of blood cells in a healthy adult human. In terms of the 4 to 10,000 cells, in terms of hematology, the term uses total leukocyte count. While in this 4 to 10,000 cells, about 40 to 70% are neutrophils, 20 to 45% are lymphocytes, 2 to 10% are monocytes, 1 to 6% are eosinophils, and less than 1% are basophils. These are different counts of leukocytes, and the term uses differential leukocyte count. We know classically during all acute infections, all acute inflammations, all bacterial and viral acute infections, the primary differential count which changes is off. Anyone?
Neutrophils.
Yes. And similarly, during all chronic infections, for example, Mycobacterium tuberculosis, classical one, cancers, and chronic inflammations, among the differential leukocyte count, the primary reflective of the chronic conditions is?
Macrophages.
But a macrophage, usually we don't measure in the circulating blood.
Lymphocytes.
Lymphocytes.
Neutrophils.
In chronic conditions में chronic inflammation, chronic infection, cancers, lymphocytes. I hope everybody remembers the lymphocytes. One of the lymphocyte, which is T lymphocytes, secrete what is called as tumor necrosis factor, alpha. And therefore, tumor is not usually an acute condition. It's a chronic condition. Same is the case for tuberculosis, which is a chronic infection. Chronic arthritis, which is again a chronic condition. All chronic inflammatory or cancerous condition. The classical main one, which is going to be the first line of defense, are lymphocytes, along with macrophages and monocytes. So, talking about the function of the first one in detail, polymorphonuclear. Why polymorphonuclear? Because they have got more than 2 lobes of the nuclei. Neutrophils, they are through the chemotaxis phagocytic, especially acute conditions, in response to interleukin 1, interleukin 8, leukotriene B4, interferon gamma, complement component C3A and C5A, and one of the free radicals, which is hydrogen peroxide. These all indicated in red are highly chemotactic to the neutrophils to perform their phagocytic function. And how they perform? They perform once the bacteria or the virus is inside them after endocytosis. It will be destroyed through the following enzymes and chemicals present inside the neutrophils, and these are superoxide dismutase, myeloperoxidase, NADPH oxidase. These first three will tackle the free radicals and their toxins. Defensins, and defensins will make pores in the cell membrane of bacteria and viruses, which will burst after the water enters them. Serine proteases, and as the name suggests, they will do the proteolysis. Alkaline phosphatase, lysozyme, which is a strongly bactericidal, lactoferrin, histaminase, cathepsin, gelatinase, and collagenase. These are the enzymes present inside the neutrophils, which helps the neutrophil to undergo its defensive function during acute infections and acute inflammations, especially which are done by bacteria or fungi. Then comes the role of the second one in terms of the granulocytes. The first one was neutrophil. The second one is eosinophil. Now, eosinophil, the main function, main एक ही होता है बेटा, is it's a very, very strong anti-parasitic type of the blood cell. And how does it do that? It secretes major basic protein, which is highly larvicidal, destroys the larvae forms of the parasites and helminths. However, the eosinophils also secrete some other substances which include peroxidase, aryl sulfatase B, phospholipase D, histaminase, and all of them, especially the histaminase, along with mast cells and basophils, is involved in allergic responses and during the pathogenesis of bronchial asthma. So being anti-helminthic, destroying the parasites, especially the intestinal parasites, and also acting during the type 2 hypersensitivity reactions, during allergic responses along with basophils and mast cells, and also in type 1 hypersensitivity reactions, they have an anti-allergic role. The third type of the granulocytes are basophils. Basophils, in contrast to neutrophils, are non-phagocytic. However, they release very powerful anti-allergic substances, including histamine, which also do the vasodilatation, tumor necrosis factor and interleukin-4, which modulate endothelial adhesion molecules. Tumor necrosis factor, we know, is involved in necrosis of tumor tissue. Interleukin-4 is an inflammatory cytokine, and heparin, which is a natural anticoagulant. So therefore, if somebody asks you the functions of basophil, they are mediators of type 1 hypersensitivity reaction along with IgE and mast cells. And they are involved in, therefore, some of the allergic conditions, including bronchial asthma. However, because they secrete heparin, they also provide anticoagulant functions. And because they secrete histamine, wherever the histamine will go, will do the vasodilatation. And vasodilatation is one of the important feature of redness,
Histamine.
swelling, and pain.
Histamine. Inflammation.
The process of inflammation, and therefore, by secreting histamine, basophils will be involved during the process of inflammation. Then comes non-agranulocytes. And these includes monocytes and tissue macrophages. They are the strongest phagocytic blood cells. And as I said, they are primarily involved in chronic infections, including Mycobacterium tuberculosis infection. One of the important functions of monocyte macrophage reticuloendothelial system, which is present in which organ? This is one of the organ in the adult human being where all destroyed old or abnormal blood cells or dead cells or denatured cells goes through circulation are removed from the body by being destroyed and phagocytosed by this monocyte macrophage reticuloendothelial system. Can anybody name the organ?
Spleen.
Organ, if becomes enlarged and enlarged can rupture and can become lethal. Spleen. Splenomegaly, due to abnormal accumulation of these all destroyed products, if becomes so much enlarged that it may rupture, तो ये सारी चीजें dead हैं बेटा, इनमें से toxins release होंगे and they can be lethal. So rupture of a spleen due to any cause in the human body can be lethal. So by normal monocyte macrophage reticuloendothelial system present in the normal healthy body, in the spleen, they may destroy the old and abnormal red blood cells, white blood cells and platelets. Can somebody give me the average lifespan of erythrocyte?
120 days.
Can
120
somebody
days.
give me the average lifespan of the leukocytes? Leukocytes depends upon the type of leukocytes are from hours to years. And platelets always in hours. They, when become old, their energy exhaust, they have done their function, have to be destroyed. Same is the case for any abnormal cell. So have you heard about sickle cells, which is a congenital type of abnormality? Sickle cells are destroyed by this system because they are recognized as foreign. Same is the case for any denatured cell or dead cells. They have to be removed. And removal of them is through phagocytosis done by monocyte macrophage combined action in a network which is called as reticuloendothelial system present in the endothelium of the spleen. The monocytes and macrophages are also involved in antigen presentation. They serve as antigen presentation cells. They present antigens to the T lymphocytes. Once the T lymphocytes become activated, they can destroy those antigens. Some of the monocytes and tissue macrophages secrete tumor necrosis factor alpha, interleukin 1 and interleukin 2, which are involved during inflammations. And as I said, tumor necrosis factor alpha, which is secreted by some of the monocytes, protects against tumors. So these are the main functions of the monocytes and tissue macrophages. The last one, in terms of the leukocytes, are lymphocytes. And they are of the following 4 types. Number 1, those T cells whose surface has got CD4 receptors, and they are called as CD4 positive T cells, or also called as T helper cells. What they do is they release cytokines including of interferon gamma, which is involved in chronic inflammations, tumor necrosis factor beta and interleukin 10, all involved in chronic inflammations and acquired immunity. The T helper cells also is involved in secretion of some of the growth factors that regulate other immune cells. The second type of the T lymphocytes have got surface receptors which are CD8, and therefore they are called as CD8 positive T cells, also called as T suppressor cells. And as the name suggests, they will suppress immune responses after invading organisms are destroyed. Why? Why do the dead or destroyed invading organism, the immunity has to be suppressed against it? Why? Why, once the invading organism has been destroyed, a suppression is needed for immune responses against them? Why?
Because they resemble body cells.
Yes. And therefore, it is initially difficult by the body, क्योंकि अब तो वो dead हो चुके हैं ना, destroy हो चुके हैं, तो active तो है नहीं invading organism, to be removed. And this immunity against them, the response comes from the T suppressor cells. Therefore, the T suppressor cell disrupt host injurious immune responses. Then the third one, which is most important among the four, among the three types of T cells, are called as cyto means cell, toxic T cells. They do what is called as lysis of virus infected cell. I hope you know virus cannot be destroyed completely. You can destroy the cell infected by the virus, but not the virus itself. And therefore, there are no antibiotics available as bactericidal. Bactericidal तो antibiotics होती हैं. कोई antibiotic virus को completely destroy नहीं करता. लेकिन जो cells virus से infected हुए, they can be destroyed by cytotoxic T cells. So cytotoxic T cells will become important in, can you name some of the lethal chronic viral infections common in Pakistan? Yes.
Hepatitis C.
Hepatitis C, HIV,
HIV.
and the most famous one, जो हम सबको तंग कर रहे हैं पिछले 1.5 साल से.
COVID-19.
All of the cells infected by these viruses, the main immunity comes through cytotoxic T cells. They can also destroy the tumor cells and allograft cells, and therefore become important and host immune responses. The last ones are the second type of lymphocyte. The first three ones were T lymphocytes. The last one are B lymphocytes. All T lymphocytes, I hope you remember, are formed in the bone marrow, but to become activated, they go to a structure which is called as thymus, and therefore T. B lymphocytes are formed in the bone marrow. They go to the lymph nodes to become activated, and to the bone marrow also, where they are activated. So the B lymphocytes primarily are involved in humoral immunity, which is antibody mediated. I hope everybody remembers the structure and the detailed functions of IgA present in all body secretions. The importance of IgG and IgM in terms of its importance in primary and secondary responses against any foreign antigen, and IgE, which I have just touched in relation to type 1 hypersensitivity reactions, allergic reactions with basophils and eosinophils. The B lymphocytes, one of their other important functions is they are one of the antigen presenting cells to the T helper cells. So these are the main functions of T helper cells, T suppressor cells, which are respectively also called as CD4 positive and CD8 positive T cells, cytotoxic T cells, and B lymphocytes. Any question, any query, anything which is not clear till now?
सर एक क्वेश्चन ये पूछना था कि आपने CDT सप्रेसर सेल्स का बताया ना, तो ऑटो इम्यून डिजीजेस जो है उनमें क्या इनका कुछ डिफेक्ट वगैरह है या फिर मतलब इनका अलग है?
Yes, they are involved in some of the autoimmune disease, but how? The exact mechanism is still debatable. The researches are there. They are involved in autoimmune diseases, but how? Not all immune diseases, not all autoimmune, in some. But the exact mechanism is not 100% known. All of the mechanisms are being suggested. जी
सर
बेटा, any
ये
other-
साइटोटॉक्सिक टी सेल्स के ऊपर कोई इस तरह के सर आइडेंटिफिकेशन मार्कर्स होते हैं जैसे CD8 और CD4 के होते हैं?
Yes, होते हैं बेटे वो. Once you go to, I am talking about physiology. Once you go to pathology, there are specific markers which the pathology people will tell you. उनकी इंपॉर्टेंस पैथोलॉजीज में है, फिजियोलॉजिकल आइडेंटिफिकेशन में नहीं है उन मार्कर्स की.
Thank you, sir.
Because I am talking about all normal functions primarily, therefore I haven't touched. ये जो CD4 और CD8 है, इनकी physiological importance भी है इन markers की. They are identification markers for T helpers and T suppressor cells. Any other question? So, thrombocytes, I hope you know, are formed in the bone marrow in the form of what are called as megakaryocytes, which are the largest blood cells. Once they are required by the body, the megakaryocytes give rise to thrombocytes. Thrombocytes don't have a nucleus. They have a short lifespan. They have granules, which are called as alpha granules and dense granules, which I'll be talking tomorrow. They releases the following: serotonin, ADP, calcium, thromboxane A2, which are involved in platelet activation, platelet aggregation, and localized vasoconstriction. All three are involved in normal hemostasis, and I'll be talking in detail about them tomorrow. The second one, which is called as von Willebrand factor, and the absence of it give rise to von Willebrand disease. One of the source of von Willebrand factor is platelets. The other source is normal vascular endothelium, which is intact. What it do is it promotes platelet adhesion and also stimulates, activates factor 8. And again, platelet adhesion and role of clotting factor, activated form of factor 8. I'll be discussing it tomorrow. Clotting factors 1, 5, 8, 12, and 13. One of their source, they have got more than one source. One of their source is platelets. Then once the tissue damage, whether it's vascular tissue or surrounding tissue, is done, the tissue has to be repaired by increasing the mitosis of vascular smooth muscle fibers. This function is done by one of the secretion of platelets, which is called as platelet derived growth factor. Is pure word mein the most important thing is growth, and growth is the growth of the scar tissue during the tissue repair. And the last one which I want you to remember is beta thromboglobulin. It's a type of globulin, and because it is released from the thrombocyte, is called as thromboglobulin. What it do is it is involved in megakaryocyte maturation. And I hope by now you know that megakaryocyte are the largest cells, precursors of the thrombocytes. They also are involved in activation of plasminogen. And if you remember my previous slide where I was talking about plasma protein, I have referred to the role of plasminogen, which is the inactive form of plasmin, in dissolution of the clot. So these are the various chemicals released by the platelets. So if I ask you, what are, just in seeing this slide, what are the 4 or 5 major functions of platelets? Can somebody tell me?
Tissue repair.
What is the major most important function? Major एक ही होता है बेटा, main एक ही होता है.
Clotting.
Platelet stop the bleeding. Platelet
Formation of platelet plug.
Please mute, please. सब दूसरे लोग डिस्टर्ब हो रहे हैं.
Platelet can stop the bleeding by itself by forming dash. What is your
Platelet
previous
plug.
knowledge?
Platelet plug.
Platelet plug. And the platelet plug formation involves the steps which are called as platelet activation, platelet adhesion, and platelet aggregation. These all steps are promoted by a number of chemicals, and platelet plug is also called as primary hemostasis. I'll be referring it tomorrow. Then the second function is, because platelet itself releases some of the clotting factors, it will be involved in clotting, coagulation, or clot formation also. The third one, because it releases beta thromboglobulin. Once the coagulation has been done, that clot has to be lysed by the help of fibrinolysin, which is plasmin. And plasminogen, one of the source of the activation of plasminogen is this chemical, which is called as beta thromboglobulin. And in minor injuries of vessels, you don't need platelet plug. You don't need a clot. You need a localized, powerful, acute vasoconstriction. In fact, this is the first step in hemostasis, which I'll be talking tomorrow. So the platelets is involved in all three mechanisms for stopping the bleeding. In sequential, one, localized vasospasm at the site of injury, especially if the injury is minor or the blood vessels are small sized blood vessels. Two, in the platelet plug formation, which is also called as primary hemostasis. And three, by promoting the coagulation itself. So platelets have got role in all three hemostatic mechanisms, and I'll be referring in detail tomorrow. Just remember the chemicals which are shown here, and I'll be referring them again tomorrow. Is it clear till now? I hope
Yes, sir.
your undergraduate knowledge is being revised और थोड़ी सी increase भी हुई होगी till now in
Yes,
terms of
sir.
properties and functions of various components of blood, including the cells and the plasma proteins.
Yes, sir.
Okay, can somebody tell me what is the cell of the blood which I haven't touched till now in detail? Because my last slide of the first lecture is pertaining to that. So I've talked about plasma, including plasma proteins. I've also talked about neutrophils, eosinophils, basophils, monocytes and macrophages, the T lymphocytes, B lymphocytes, thrombocytes. What remains?
RBCs.
Yes. And the last one are RBCs or erythrocytes. We know, I hope everybody remembers the biochemical structure of erythrocyte, which consists of heme and globin. Heme further consists of pyrrole ring. And the pyrrole ring, if you do remember, contain the binding site for oxygen, which is iron. 1 gram of hemoglobin can carry in blood circulation up to 1.34 ml of oxygen. However, the hemoglobin can also bind carbon dioxide. Once hemoglobin binds oxygen, this will be called as oxygenated hemoglobin. If hemoglobin binds carbon dioxide, it is called as amino hemoglobin. However, hemoglobin can bind two more things normally if they are in excess. Can somebody name two other things other than oxygen and carbon dioxide with which hemoglobin can normally bind? Yes, and if it binds with carbon monoxide, it is called as carboxyhemoglobin. One more thing which it can bind, and if it binds that, hemoglobin acts as buffer.
Methemoglobin.
ना बेटा नॉर्मल की बात कर रहा हूँ. मेट हीमोग्लोबिन नॉर्मल
कार्बन डाइऑक्साइड
नहीं बेटे, कार्बन डाइऑक्साइड से तो बाइंड कर गई ना, वो बात हो गई. कार्बन डाइऑक्साइड, ऑक्सीजन, कार्बन मोनोऑक्साइड की बात हो गई. इट कैन बाइंड नॉर्मली. मैं अगेन रिपीट कर रहा हूं, जो मेरा क्वेश्चन बताएगा 5 सेकंड में उसको 100 रुपए मिलेंगे. इट कैन बाइंड डैश to act as a buffer.
Bicarbonate.
No, it can bind hydrogen. And once it can bind hydrogen, it becomes what is called as reduced hemoglobin. जी मैंने इसलिए 5 सेकंड कहे थे. So once it can bind hydrogen, it becomes reduced hemoglobin. I hope everybody remembers hemoglobin oxygen dissociation curve. Which one has more affinity to bind oxygen? The adult hemoglobin or the fetal hemoglobin?
Fetal.
Fetal hemoglobin.
And I hope you remember the role of 2,3-diphosphoglycerate in terms of competing with oxygen to bind with hemoglobin in that oxygen hemoglobin curve. Same is the case for hydrogen. If hydrogen binds with hemoglobin, it reduces the total binding of the oxygen. And therefore, if hydrogen is able to bind with hemoglobin, hemoglobin can take this hydrogen binded with it to the kidney where it can be removed. And this hemoglobin acts as one of the buffer. This reaction, which I have already talked in my lecture today, this is present inside the RBCs. I have also talked about chloride shift in terms of erythrocytes. Hemoglobin allows carbon dioxide to combine directly with amino acids to form what is called as carb amino compounds. And the last important function of hemoglobin, of erythrocyte, which is not related to carriage of respiratory gases, is its surface has got blood group antigens, which are called as agglutinogens, which serves as identification. And these are the blood types, which is my next lecture. So I have intentionally used the last sentence to continue for my next lecture, which I'll start in next 5 minutes. So what I have done today is from 11:30 to 12:30, I have tried to give you an overview and outline of the composition, the percentages, the amounts of the plasma and the blood cells. I have talked about in detail about the plasma proteins and their functions. I have also given you some examples and their importances in the clinical and applied cases. I have talked about it and given you an overview of the composition and functions of different type of the granulocytes and agranulocytes. I have talked about and given you the main functions of the thrombocytes. And in the last slide, I have talked about erythrocytes. Has this discussion made any contribution in your previous knowledge?
Yes, sir.
Yes, sir. Excuse me, sir. Please elaborate about carb-amino compounds. That what are their functions or roles, maybe?
So once hemoglobin lets carbon dioxide to combine directly with amino acids, the structure formed is carb amino compounds. Now there are many amino acids which are, I hope you know that we divide the amino acids in essential and non-essential.
Yes, sir.
There are many amino acids which are still inactive in their own form. They become active only once some substrate is attached to them. And one of the substrates which makes some of the amino acids to become active is carbon dioxide. So therefore, those amino acids with which carbon dioxide combines makes them relatively active.
So the hemoglobin acts as an enzyme, maybe we can say.
No, not an enzyme, but a cofactor.
Okay, sir. Thank you.
Any other question, beta?
Sir, which amino acid acts as a buffer? It acts as a buffer to accept hydrogen ions.
अमाइनो एसिड एक्ट एज अ बफर. मैंने तो अमाइनो एसिड की बफर की बात ही नहीं की बेटे. मैंने आपसे कहा once hemoglobin combined with hydrogen, it is now called as reduced hemoglobin. जब हाइड्रोजन कंबाइन हो गई तो क्या वो फ्री है? बेटे अगर हाइड्रोजन कंबाइन हो जाए हीमोग्लोबिन से तो क्या वो फ्री है सर्कुलेशन में, ब्लड प्लाज्मा में?
No,
तो ये हीमोग्लोबिन जो अब रिड्यूस्ड हीमोग्लोबिन है, इस हाइड्रोजन को बाइंड करके किडनी तक ले जाएगा, किडनी सेल्स में रिलीज कर देगा, और किडनी सेल्स में हमने फेट देख लिया हाइड्रोजन का कि कैसे कैसे रिमूव होती. डू यू गेट द कंसेप्ट?
Yes, okay. Thank you.
So I'll be continuing after 5 minutes of my discussion about the blood types and blood groups.
Okay, sir.
टोटल पूरा करने के अलावा कुछ दफा कमेंट्स लिखना इम्पोर्टेंट होता है, उसी से हम इम्प्रूव करेंगे. इसलिए नंबर इम्पोर्टेंट नहीं है, जो आप सजेस्ट करोगे ना अगली दफा उसी से तो चीजें मॉडिफाई बेहतर हो सकती है. अभी मैं लेक्चर ले लूं तो फिर अपने वाले मैडम से कहना तेरे वाले निकाल. Okay, Assalamu alaikum again. Can you hear me?
Yes, sir.
Yes, sir.
Can you see me?
No, sir.
Yes, sir.
Okay. I can see you with your feedback. Okay, so starting with my second lecture today. Beta, your feedback is so critical to all of us, including the administrative staff of CPSP, because the things which we have organized this time will improve only by your feedback, and it's still more than half a way to go for this course also.
There is always room for improvement.
So for example, I know about me, I have got 6 more lectures in next 5 days. How can I be modifying myself according to your needs and improve if you don't get feedback instantly? और फीडबैक आज के आज ही दोगे, परसों तो मुझे तुम्हें याद भी नहीं रहेगा कि क्या था. So please provide your feedback to CPSP about these individual lectures. So should I start my second lecture, beta?
Yes, sir.
Yes, sir.
Okay. So I'll be talking and trying to cover all major aspects of the physiology in terms of the blood groups, which are also called as blood types. I'll be trying to relate the various blood types, their agglutinogens, agglutinins, phenotypes, and genotypes with their individual physiological and clinical significances. We know that every erythrocyte which we acquire, inherit from our father or mother during embryogenesis and thereafter, each erythrocyte has got on its surface specialized antigens which are called as agglutinogens. Why agglutinogens? Because if they cross-react with antibodies which are not same, they will form clumps. And the process of formation of clumps by agglutinogen, which is opposite to that agglutinin or the antibody present in the plasma, the process of this clumping is called as agglutination. And therefore, the antigen inherited from the parents on the surface of the erythrocytes are called as agglutinogens. They were first discovered by a Nobel Prize winner laureate whose name was Karl Landsteiner. He belonged to Austria, and this was in 1900. And he discovered the ABO blood group system. From that day till now, there are more than 30 types of the blood group system which have been identified. They all are not important. 2 group systems among them are called as major blood group systems. They are the ones which are mainly involved in the blood transfusion abnormal reactions. While many more than 2 group systems among the 30 are called as minor blood group systems. They are either named on the person in which blood they were discovered as the disease process or due to some other significance. So the blood group systems, they all have
प्लीज म्यूट। ये तो मुझे किसी कैट की आवाज आ रही है बीच में ना, किसी बच्चे की आवाज है।
So whether you talk about ABO blood group system or RH blood group system, the blood group antigen, which is also called as agglutinogen, will always be present on the surface of the RBC, while its antibody will be present, and the antibody is called as agglutinin in the plasma or the serum of that person. And as I said, if an agglutinogen cross reacts from the antibody which is not similar to the agglutinogen, will cause the clumping of the cells, and this is called as heme agglutination, which is shown in this diagram. So the clumping occurs of the unlike, not similar agglutinogen and agglutinin. And if agglutination occurs, this sort of agglutination, which is due to agglutinogen present on the RBC surface and its cross reaction with agglutinin present in the plasma. And if the antigen antibody are opposite to each other, then this sort of appearance occurs, which is called as heme agglutination. And this is what actually occurs in mismatch blood transfusion. What it do is, it leads to hemolysis of that RBC on which agglutinogen was present. So let's suppose I donate a blood. I don't know what my blood agglutinin is in my plasma, to a person who don't know what agglutinogen on his RBCs are. If I am a donor, if my agglutinin in my plasma cross reacts with agglutinogen, which is not similar to me means my agglutinin, it will cause same sort of picture, which is called as agglutination, and will result in hemolysis of the recipient's RBC. This is called as mismatched blood transfusion, and this is due to abnormal heme agglutination and hemolysis. Are you with me till now? So if I ask
Yes, sir.
you, where is, for anybody, मेरी body में बेटे agglutinogen भी होगा, agglutinin भी होगा. Agglutinogen मेरी body में RBC के surface पे होगा, which is called as blood antigen. और उसके उस जैसी antibody मेरी plasma में होगी, which is called as agglutinin. A person having blood group A, which is blood agglutinogen A, will have antibody which is not A but anti-B. I again repeat, a person whose RBCs contain blood group agglutinogen A will have in his plasma or serum anti-B type of agglutinin. A person whose blood group is B, that is, his RBCs contain agglutinogen type B, will have in his or her blood anti-agglutinin A, the opposite one. A person who has got both types of agglutinogen on his RBC surface, that is, he or she has agglutinogen A as well as agglutinogen B on the surface of his RB or her RBCs, will have no antibody in his serum, neither antigen and agglutinin B, neither agglutinin A. The person whose RBCs lack both agglutinogen A as well as agglutinogen B is said to have blood group type O. So blood group type O means on his RBCs, neither agglutinogen A is present, neither agglutinogen B is present. But this person who lacks both agglutinogens will have both anti-B and anti-A agglutinin in his or her serum. Are you with me?
Yes, sir.
Yes, sir.
Yes, sir.
The difference between agglutinogen A and agglutinogen B, and this was not my knowledge when I was a first year MBBS student. This I came to know once I was involved in research. Group A, type A, blood group type A, the terminal sugar on agglutinogen type A is N-acetyl glucosamine. The terminal sugar on type B agglutinogen is galactose. So the difference between A and B agglutinogen is on the basis of their terminal sugar. For blood group A agglutinogen, this is N-acetyl glucosamine, while for B blood group agglutinogen, the terminal sugar is galactose. Their precursor antigen is called as H antigen. They are represented on chromosome 9 in terms of their inheritance and genetics. Agglutinogen A and B, their biochemical nature is they are complex oligosaccharides. Anti-B, which is present in blood group A, and anti-A, which is present in blood group B. These antibodies are IgM in their nature. They are produced spontaneously by sensitization care of food, bacteria, or viruses during embryonic life. So, the new knowledge as compared to your undergraduate knowledge may be that the agglutinogen A and B differs on the basis of their terminal sugar. For agglutinogen A, the terminal sugar is N-acetyl glucosamine, and terminal sugar for agglutinogen B is galactose. They are inherited through chromosome number 9. They are their antibodies, which is anti-B for type A and anti-A for type B. Their agglutinin, they are complex oligosaccharides in nature. While the agglutinins of the respective groups, these agglutinins, which are antibodies, are IgM in nature. And once the fetus was embryologically developed, how did these antibodies develop? देखो एंटीजन तो आएगा फादर और पेरेंट्स से ना, बट उसके खिलाफ एंटीबॉडी कहां से है? वो तो फादर मदर से नहीं आएगी. It is produced spontaneously for ABO blood group system by sensitization. The word uses sensitization, care of food, bacteria, or virus. So ABO blood group is one of the natural blood group. Natural Q, because we have inherited naturally from our parents. We have inherited agglutinogens, either A or B or both, or neither of them. And therefore the blood group was A, B, AB or O respectively. In A, the agglutinin is anti-B. In B, the agglutinin is anti-A. In AB, there is neither anti-B, neither anti-A. In blood group O, there is both anti-B and anti-A agglutinin, while blood group O is the only one which don't have A or B agglutinogen or antigen on its surface. So therefore, blood group O sometimes is referred as universal,
Donor.
and blood group AB is sometimes referred as universal.
Recipient.
Thank you.
Recipient.
The second blood group system is called as rhesus, and this was discovered, we know famously, in the rhesus species of the monkey. This is also called as Rh factor or Rh agglutinogen. And there are 6 types of the Rh agglutinogens, which include capital D, capital C, capital E, small d, small c, and small e. Among rhesus blood group system, these 6 agglutinogens are possible. However, the commonest one is capital D. Any person who has got agglutinogen capital D on his or her red blood cell surface do not have small d agglutinogen. Same is the case for C and E. Therefore, any person who may have capital C will not have small c. Similarly, any person who has got capital E will not have small e agglutinogen on his or her RBC surface. However, out of these DCE, capital and DCE small, the commonest one is D. And therefore, if any person has got capital D on his RBC surface positive, he is said to have Rh positive blood group. And this is represented during genetics and inheritance on chromosome number 1. Anti-Rh agglutinin are either IgM or IgG type. Therefore, in comparison to ABO blood group system, the Rh agglutinins, which are antibodies, can cross placenta. And this is what the reason why the disease, which I hope you have learned in your undergraduate, which is called as hemolytic disease of inborn or erythroblastosis fetalis occurs. And this is because the anti-Rh antibodies can cross placenta. If the mother is Rh positive and the baby is Rh negative, both have got opposite agglutinogens on them. One has got agglutinogen D present, which is mother, and fetus, which don't have the Rh D agglutinogen on his or her erythrocyte surface. Once the delivery occurs, once during the pregnancy, if the antibody crosses through the placenta, it can cross-react with the mother's agglutinogens, and the newborn baby, because the agglutinogen and agglutinin are opposite of the fetus, will undergo hemagglutination and hemolysis. To prevent it, erythroblastosis fetalis, we know that within 48 hours of the delivery, to be prevented in the next pregnancy, anti-Rh antibody is given to the mother who has just delivered the baby to prevent erythroblastosis fetalis in the next pregnancy. The antibodies against Rhd agglutinogen, for them, the person must first be massively exposed to an Rh agglutinogen by blood transfusion or post-pregnancy before enough agglutinins are there to cause a transfusion reaction, which is often a delayed type reaction. So if by this definition, if I ask you कि अगर जब तक इतनी तादाद में एग्लूटिनिन्स ही नहीं बने either during pregnancy or after blood transfusion, तो जो blood transfusion reaction है वो severe किसका होगा, against ABO system or against RH system?
RH system.
ABO.
ABO what will be acute and more severe. The blood transfusion reaction against RH agglutinogen or agglutinin will be less severe and will be often delayed. And therefore, the erythroblastosis fetalis may not be in the first pregnancy, it may be in the successive pregnancy if the mother has not been immunized against that fetal antibody. It is to be noted that both ABO agglutinogens or RH agglutinogens are naturally acquired. They are inherited. However, the minor blood group systems which have been named in most of the cases on the names of the person in which they were identified or diagnosed, and all those persons were deceased persons, they are not naturally occurring. And these include Duffy, Kidd, Kell, Lewis, Lutheran, MNS. These are some of the minor blood group types. So two main differences between major and minor. Major are always inherited. Minor are not inherited, they are acquired during a disease process. The blood transfusion reactions against major are severe. However, the blood transfusion reactions against minor blood groups are usually either rare or less severe. Now, this is an important chart which shows the phenotype and genotype. The blood group A has a phenotype which is either AA or AO, and has the genotype which is AA or OA. The person will have agglutinin NTB. The person can donate the blood to blood group A or AB and can receive the blood from A or O. The blood group B, the phenotype is either BB or BO. The genotype is BB or OB. The person has got agglutinogen B, while he or she has got NTA. Hamesha opposite hoga. He or she can donate the blood group to the blood group B or AB and can receive the blood from blood group B or O. Keeping in mind, we have just termed that blood group O is usually universal donor, while AB is universal recipient. The blood group AB will have both phenotype, will have phenotype AB as well as genotype AB, will have both A and B agglutinogen, while he or she has neither NTB nor NTA, therefore no agglutinin in his or her plasma, and therefore is the reason for him or her to be universal recipient. Can donate the blood only to blood group AB and can receive the blood from AB and the universal donor, which is blood group
O.
The last one, the person with blood group O has a phenotype which is OO and genotype which is again OO. He or she don't have agglutinogen A, also don't have agglutinogen B, so lack both agglutinogens. However, he or she has both NTB and NTA and therefore universal donor. Can donate blood to O, A, B, and AB, practically to all four types of the ABO blood group persons. However, can receive blood only from blood group O. And especially if the person is O negative, it is very difficult to have the blood group readily available during blood transfusion requirements. Are you with me? Is this chart clear?
सर एक क्वेश्चन है
जी बेटे.
सर क्वेश्चन ये है कि ब्लड ग्रुप ए बी के पास दोनों एंटीजेंस हैं ए और बी, और ब्लड ग्रुप ओ के पास दोनों एंटीबॉडीज हैं ए और बी, तो सर जब ओ ट्रांसफ्यूज करेगा ए बी को तो ब्लड ट्रांसफ्यूजन रिएक्शन नहीं होगा एंटीजन एंटीबॉडी का?
बेटा द देखो, जब ओ ने ब्लड डोनेट किया ए बी को, तो ओ की हम क्या चीज देख रहे हैं? ओ में है क्या? एग्लूटिनोजन तो है ही नहीं, तो हम ओ की देख क्या रहे हैं चीज? एंटीबॉडी देख रहे हैं ना। तो एक आदमी की एंटीबॉडी जो कौन कौन सी है? एंटी बी और एंटी ए, ये ब्लड ग्रुप ओ है। और दे किसको रहे? ए बी को। बेटे उसमें तो एग्लूटिनोजन है ही नहीं, तो रिएक्शन होता है एंटीबॉडी और एंटीजन के दरमियान। तो एक की एंटीबॉडी दे रहा हूं जिस एक दूसरे को, उसमें एंटीजन है ही नहीं, तो ये एंटीबॉडी ओ वाले की रिएक्ट किस एग्लूटिनोजन से करेगी? उसमें तो है ही नहीं। क्रॉस रिएक्शन देखते हैं रेसिपिएंट की एंटीबॉडी और डोनर का एग्लूटिनोजन और वाइस वर्सा। आर यू विद मी? बेटे जो क्रॉस रिएक्शन होना है ना, रिएक्शन होना है, वो होना है डोनर का एग्लूटिनोजन और रेसिपिएंट की एंटीबॉडी और वाइस वर्सा। तो अगर ओ ब्लड ग्रुप का मतलब क्या है? इसके अंदर एंटीबॉडीज कौन सी हैं?
ए एंड बी।
एंटी बी है और एंटी ए है। मैं एक ऐसे आदमी को ब्लड ग्रुप ओ की एंटीबॉडीज दे रहा हूं जिसमें एग्लूटिनोजन है ही नहीं। भाई कहां है ब्लड ग्रुप एग्लूटिनोजन ए बी में? देखो ए बी में नाइदर एंटी बी है नाइदर एंटी ए है। एग्लूटिनिन कहां है? दोबारा बोलूं?
हम सर पर उसमें एंटीजन तो है, एंटीजन ए बी और एंटीजन बी।
ब्लड ग्रुप मैंने दिया, डोनर है ओ, डोनर है ओ में एग्लूटिनोजन है कोई?
नो सर।
अब एक डोनर का मैं ब्लड दे रहा हूं, उसमें एग्लूटिनोजन नहीं है, और मैं दे किसको रहा हूं? ए बी को। ए बी में क्या एग्लूटिनिन है?
नहीं सर।
तो नहीं सर। दोनों में शर्त ये डोनर और रेसिपिएंट में कि दोनों में एग्लूटिनोजन भी हो और एग्लूटिनिन भी हो। एक में एग्लूटिनोजन नहीं है जो ओ है, और एक में एग्लूटिनिन नहीं है जो ए बी है। तो डोनर और रेसिपिएंट, भाई मैं एग्लूटिनोजन और एग्लूटिनिन अलग अलग करके तो नहीं दे रहा ना, मैं पूरा ब्लड ट्रांसफ्यूज कर रहा हूं ओ का ए बी को। आर यू विद मी? बेटे जब मैंने ब्लड दिया ओ का, तो ब्लड में क्या क्या चीज होनी चाहिए? भाई दो ही चीजें हैं ना, एग्लूटिनोजन और एग्लूटिनिन। ओ के ब्लड ग्रुप में कोई एग्लूटिनोजन था?
नहीं।
एग्लूटिनोजन नहीं था, तो वो अगर ब्लड पहुंचा ए बी में, तो वो एग्लूटिनोजन था ही नहीं, तो रिएक्शन कैसे होगा एग्लूटिनिन से बी ए बी के? वाइस वर्सा। अगर फर्ज करो कि मैं ब्लड ग्रुप ओ के एग्लूटिनिन की बात कर रहा हूं, तो ये जो एग्लूटिनिन है, कौन कौन से एग्लूटिनिन है ओ में?
एंटी बी एंटी ए।
तो ये एग्लूटिनिन तो है लेकिन एग्लूटिनोजन नहीं है। अगेन जब वो ए बी में गया, तो क्या ए बी में कोई एग्लूटिनिन था? भाई चार्ट बता दो, इसमें क्या ऐसा साइंस है? नहीं कोई।
नहीं।
तो बेटा जब एग्लूटिनिन ही नहीं है ए बी में, तो वो ओ के एग्लूटिनोजन ओ में क्या था कोई?
नो।
तो बेटा रिएक्शन कहां होगा? एक में एग्लूटिनोजन नहीं है, एक में एग्लूटिनिन नहीं है। अगर हम ओ की बात करें, ओ में एग्लूटिनोजन नहीं है, इसको कागज पे बना के देखो, ओ में एग्लूटिनोजन नहीं है। मैं अगर एग्लूटिनोजन नहीं है और इस ब्लड को इसके अपोजिट वाली एग्लूटिनिन से एक्सपोज भी कर दूं, तो जब एग्लूटिनोजन नहीं है तो रिएक्शन कहां से होगा? एंटीजन एंटीबॉडी रिएक्शन ही होता है ना बेटा। डू ब्लड ग्रुप ओ हैज एनी एंटीजन और नॉट?
नो एंटीजन।
तो जब एंटीजन ही नहीं है, तो मैं ब्लड अगर दे भी दूं, तो ब्लड ग्रुप ओ हैज नो एंटीजन, तो एंटीबॉडी से ब्लड एक्सपोज हुआ लेकिन एंटीजन था नहीं उस ब्लड में, तो रिएक्शन कहां हुआ?
सर जो एंटीजन
बात समझ में आई? बेटे मैं अगर एक चीज है ही नहीं उस ब्लड में और वो ब्लड दे दूं मैं, एक एक ब्लड, देखो इसको अगर इन विट्रो करो, एक स्लाइड पे ऐसे ब्लड पड़ा हुआ है जिसमें एंटीजन नहीं है। मेरी बात गौर से सुन रहे हो?
यस सर।
बेटे एक स्लाइड पे एक ब्लड सैंपल पड़ा है, उस सैंपल में एंटीजन नहीं है ही नहीं, ना ए है ना बी है। अब मैं उसके ऊपर एंटीबॉडी डालता हूं, जब उसमें एंटीजन ही नहीं है तो कोई रिएक्शन होगा इस एंटीबॉडी का?
नो।
तो दिस इज द केस फॉर O. So if you give O which lacks agglutinogen, even the blood from this blood person, from the person who has got blood group O, because it will have no agglutinogen, will not therefore have any reaction with agglutinin B or agglutinin A, which is in the opposite blood, and vice versa for AB. इसको कागज पे जब तक बना के नहीं करोगे उस वक्त तक समझ में नहीं आएगा। Any other question?
सर आपने कहा कि रिसर्च सिस्टम के अंदर सी और ई भी होते हैं ना, लेकिन मतलब हम पॉजिटिव और नेगेटिव तो सिर्फ डी की बेसिस पे कर रहे हैं, तो फिर हम लोगों ने मतलब सी और ई के लिए तो वो ही नहीं किया, मतलब स्क्रीनिंग ही नहीं की, तो उससे रिएक्शन नहीं हो सकता?
उससे रिएक्शन हो सकता है, माइनर एंड रेयर। So out of, let's say, 100 people, if 90% of the people have got only D, तो वो जो बाकी 5 रह गए वो 10% में डिवाइड होंगे। तो 90 जो ज्यादा तादाद में जिन लोगों के एग्लूटिनोजन है डी, उनके रिएक्शन होने के ज्यादा चांसेस हैं या 1-2% वालों के ज्यादा चांसेस हैं? Do you understand this concept?
जी सर, थैंक यू।
So, at the end of the story, if somebody asks you what is the physiological significance and clinical, one, the major blood group systems are used for personal identification, especially when it is related to exposure to a hospital for pregnancy, for any other diseases. It is a pre-requirement for blood transfusion to do the blood typing and cross-matching. Cross-matching is always between the agglutinogen and agglutinin of donor and recipient and vice versa. It is also used, as I referred, for prevention of hemolytic disease of newborn, erythroblastosis fetalis in terms of Rh blood group system. Many of the medico-legal cases, the paternity, the maternity, the post-mortem examination of the fresh blood samples, they may be requiring the blood group to be identified. And sometimes some specific diseases or syndromes are more common in some specific types of the disease processes. So these are some of the physiological and clinical applied significances: identification, pre-blood transfusion requirement, prevention of erythroblastosis fetalis, medico-legal cases, and for determination of frequency of disease association. This is the importance of blood groups. So what I have done today is I talked about the major and minor type of blood groups. I also talked about agglutinogens and agglutinins, both of ABO blood group system and Rh blood group system in detail. They were previous history. I also talked about in a chart related to phenotype and genotype. And I also talked about which blood group can donate the blood to XYZ and receive the blood from XYZ. And I also talked about the minor blood group systems. And at the end, I referred to the physiological and clinical significances of these blood group systems. Any question, anything which is not understood at this moment of time?
सर बॉम्बे ब्लड ग्रुप का बता देंगे आप प्लीज?
जी बेटा. So Bombay blood group was identified in our person, I'll not go into the detail, uski badi lambi history hai. And there are, by the way, now more than one Bombay group system. एक से ज़्यादा Bombay group system है research में अब. So therefore it was diagnosed in one of the patient who was residing in Bombay, which is a city in India. And the importance is that many a times the rare blood transfusion reactions don't occur due to ABO system or RH blood group system, but due to some minor blood group systems, inclusive of the Bombay blood group system. But they are very rare and they are often mild. Ji beta, anything else? You know, there is a blood group system which is called as Punjab blood group system. This is latest. जी
माशाल्लाह
ये
सर
कौन सा ये आप होमवर्क करिएगा और फिर बताइएगा. This is minor.
चलो ठीक है सर.
Sir, it is a Indian Punjab or Pakistani Punjab?
ये तो आपने होमवर्क करना है.
सर सिंध सिंध सिस्टम नहीं है क्या?
क्या नहीं है?
सिंध सिंध
सिंध सिंध का मैंने नाम नहीं सुना अब तक किसी रिसर्च में. अच्छा, बाय द वे रिसर्च में जब तक आता है, जब तक वो पब्लिश ना हो जाए और वो अप्रूव नहीं हो जाए तो उसको हम आइडेंटिफाई नहीं करते ब्लड ग्रुप सिस्टम को. ऐसे तो बहुत सारे हैं. So practically speaking, you only have to remember that the minor blood group systems only cause rare or mild blood transfusion reactions, and they are not acquired by through the inheritance. ठीक है जी?
Yes, sir.
Was I able to give you the significances and the physiological importance clear about blood
Yes,
groups?
sir.
Yes,
Thank
sir.
you. So we'll be taking a difficult, thorough, complex topic tomorrow, which is hemostasis, which includes vasospasm, platelet plaque formation, and coagulation. Thank you.
Thank you, sir.
थैंक
Thank you, sir.
कल भी हम 11:15 को स्टार्ट कर लें. 15 minutes break. 11 to 11:15. Is it okay for you
Yes.
people?
Yes,
Okay,
ma'am.
ma'am.
Yes, ma'am.
Okay. Thank you so much.
फुरकान भाई मीटिंग क्लोज कर दें, एंड कर दें।